Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Al-Mamari. I'm hematologist at Central Blood Bank. My talk today will be about transfusion reaction. The aim of the talk will be basically directed to the early recognition and management. The pathophysiology and preventive measures will not be discussed in this session. However, if you have any question later, we can discuss them. So the outline of my presentation will be focused on the following points. Introduction about transfusion reaction, classification, how we classify usually transfusion reaction, and then general approach to management of the transfusion reaction. I'll focus mainly on the life-threatening transfusion reaction because I want you to get from this lecture how to recognize these life-threatening transfusion reaction and how to manage them, which will be acute hemolytic transfusion reaction, TRALI and TACO, anaphylaxis, and later I'll discuss in a brief about the mild to moderate reaction, and in mild and moderate reaction how we usually manage the subsequent transfusion because it tends in some patients to be recurrent. And finally we will conclude this by take-home message. So transfusion reaction, though modern blood transfusion is very safe, but preventable death and major morbidity still occur. So before transfusing the patient, you have to be very careful, as Dr. Ahmed and Dr. Khalid already discussed, because inappropriate decision to transfuse put patient at unnecessary risk of transfusion error, reactions, and transfusion transmitted infection. So proper decision of a transfusion. In addition to that, you positively identify your patient, the sample you take, the sample process at lab, and the unit that come out of the lab. So usually majority of the causes of transfusion reaction are all human error because of error in identification of the patient, blood sample, and the blood component. And I hope that you have already taken workshop about positive patient identification and sample identification by Dr. Iman. I hope so. Yeah, okay. So it will be easier now to know the importance of positive patient identification, positive sample identification, because it is the root cause of many of the preventable transfusion reaction. Now to classify transfusion reaction, there are many classifications. However, the aim here not to classify the transfusion reaction. I want you to recognize that it is a reaction and how to work on it. So if we take the simple transfusion classification, for example, you can classify it as acute or chronic, with fever or without fever. You can classify it as mild, moderate, severe. You can classify it as transfusion related or other, like mechanical related transfusion reaction also. So if we take it as a transfusion presenting with fever and without fever, subclassify them into acute and delayed. So like the transfusion reaction usually present with fever and are acute, including acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, transfusion related sepsis, and transfusion related acute lung injury, TRALI. And delayed hemolytic transfusion reaction and transfusion associated graft versus host disease, with Dr. Khalid highlight on this reaction. Or the one which not presenting with fever, acute one, or kind of allergic reaction, hypotensive reaction with different causes, transfusion associated dyspnea with different causes, transfusion associated circulatory overload, TACO. Or could be delayed without fever, like delayed serological, which is like hemolytic but without fever, and post-transfusion barbara and ion overload. Now my talk today will be all about acute. So all reactions that happen within 24 hours of transfusion. So I'll focus on acute. Delayed, it will be in another session, inshallah. So when you deal with a patient who is receiving transfusion, first of all, you have to have a general principle that should be clear to all staff that dealing with the transfusion practice, starting from collection of the sample until the transfusion process itself. So when you decide you have to transfuse a patient in a clinical area where they can be directly observed by appropriate trained staff, and ensure that early recognition and management of acute transfusion reaction already incorporated in the policy that have been taught to that staff or anybody dealing with the transfusion, like the transfusion practitioner or nurses or doctors. Now, if you start the transfusion, you have to be aware about transfusion reaction. It is not easy to diagnose immediately, and it doesn't come straightforward as we read in the textbook, because the manifestation differ according to the reaction itself. And you remember that this reaction can happen and can manifest with different manifestation. So it could be inflammatory process. So patient will present with fever, chill. You have to notice that happen before. Is it the patient have fever before, or just it's a new symptom after you start the transfusion? Skin changes or pain at infusion site. All these signs should be tackled seriously, because it is a sign of starting maybe serious transfusion reaction. Circulatory symptoms like a change in the blood pressure, patient going into shock, or having hemoglobinuria. In patient who have you observe the urine color and you see that there is a change in the urine color. Pulmonary symptoms including dyspnea, orthopnea, wheezing, or patient already went into respiratory failure. And coagulation changes, like patient who received transfusion and suddenly develop unexplained increase in the bleeding, or he went in DIC. Now you see these symptoms may be overlapping and not specific, but when we discuss the transfusion reaction, the types, maybe you will get a hint to which type you can classify. But any new symptom that is started after you transfuse the patient, the one I have mentioned, it should alert the physician or the caring for the patient that patient may start to develop transfusion reaction, and you have to have a high index of suspicion. So you have to work as it is hemolytic until proving as otherwise. So you have to work as it is severe transfusion reaction until you work it up and you find it is not hemolytic, so you will be in safe side. Now, if whatever I have mentioned for the symptoms, if you follow these 5 steps when you deal with a patient who already received a transfusion, and it comes to your mind that this patient developed a new symptom, I'm thinking about transfusion reaction, you work with these 5 steps and you will manage the patient early. Whatever kind of transfusion reaction, you need to apply these 5 steps. Further workup will help you to classify your transfusion reaction. So first of all, if the patient develop a new symptoms, you stop the transfusion. You make sure that patient have IV access which is available and patent, and you ensure that he have an extra IV access as well. So you stop the transfusion, observe that you have IV access, and then you immediately check the details. You want to prevent the serious things. So you have to start thinking about ABO incompatibility. So you check the details on the patient ID and the bag. So it should be from the positive identification of the patient. Anyway, if it is missed or the things now happen, you have to double check. Is the details on the bag that patient is receiving is identical to the ID band that is in his hand? And then check vital signs and start resuscitation if necessary. So by this way, you are keeping the patient in safe side. And you at the same time you have to call for medical assistance. So you have to, from the experience, you will see that I'm dealing with life-threatening condition. I identify it. I have to have a help from medical assistance. Maybe this patient need to be shifted to ICU immediately, because majority of the serious and life-threatening transfusion reaction, though not all of them are fatal, but can be fatal. So mortality very high, and you be careful. You notify. So you call for medical assistance, and you inform the hematology or the transfusion laboratory. So you inform the and blood bank specialist anyway. So you can and inform the blood bank also laboratory. So it will ease the process of working up this patient. So these 5 steps are really very important in all types of transfusion reaction. You start them, you apply the management of the patient. Don't worry about the classification of the transfusion reaction, because it will come later after you stabilize your patient, and majority of the management is supportive. There are additional things you can do, however the initial steps are very important. Okay. Then we go to who is responsible about doing this notification and starting the workup of transfusion reaction. Now it is not one person responsibility. I think majority of you are working in a team, including doctor, including nurses, phlebotomists, whoever in the ward who is taking or daycare or the operation. So there will be anesthetist, will be different. It will be a whole team. So whoever dealing with the patient and involved in the transfusion process itself, he should notify. So either nurses or doctors or other transfusing staff should empower to contact the blood bank directly if suspicious finding occur during transfusion, applying 5 steps and notifying for help. So this will help for early management of the patient. Because majority from many study that shows suspected reaction being underreported. So many patients maybe will went through, which is real, and it happened not only in our setting, even in other country. They are underreported because of lack of knowledge and awareness. So patient, maybe I give you a real example, went to OT and come to ICU and died, and the cause was ABO incompatibility. Nobody noticed it. So a majority of these are underreported. However, if you start think about it, it is, as Dr. Khalid, the most dangerous medicine you can give to your patient. So you think that the effect of it, it's really fatal. So any suspicious after transfusion, you have to start the transfusion reaction workup. Now we'll go for the severe life-threatening transfusion reaction. You will apply the 5 steps as I mentioned. Now you have to think, after you stabilize your patient and you put him in an area which is safe and with all supportive team, you think about what type of reaction is this one. Now the life-threatening reaction usually is hemolytic transfusion reaction, which is ABO incompatibility, or other transfusion reaction like trali or TACO and anaphylaxis. Will discuss each separately. Now if your patient present with fever, we want to rule out life-threatening reaction. So is it hemolytic transfusion reaction or not? Usually this incidence, I will not discuss pathophysiology in depth, however I'll give you only a highlight about it. Usually it happens in ABO incompatible red cell if patient receive incompatible ABO group to his group. Then the patient system will produce antibody against that red cell which is incompatible to him, either by anti-A or anti-B. It is an IgM and it will result in severe intravascular hemolysis with release of intracellular component and release of interleukins, and it will end up by this cascade hemolysis to acute renal failure and DIC. You see the end result is it's really fatal, and also it needs only supportive measurement. So if it is happen and you didn't recognize it early, the patient may die, because there is no specific treatment you can give it and you revert the effect of the blood transfusion. So I'm stressing on early recognition so you can manage early. And even if you give your patient less than 30 ml of incompatible blood, if he group O and he receive A or B, he may die. Though the study shows that morbidity and mortality may be affected by the amount of blood transfused, the duration of a transfusion, and the patient system himself, because different in the outcome. However, remember this, even small amount can kill your patient. And it's almost human error in this very life-threatening reaction. Majority in different studies and different hemovigilance system, like in UK system, still human error is the first cause of this life-threatening. So like in UK hemovigilance report, they found that half of all error are due to administering properly labeled blood. Means you have worked hard and you collect that blood from the appropriate donor, you have screened it, you have worked it up for the grouping and the cross-matching, you finally label the appropriate blood, and when you issue it to the ward, there will be a mistake and it will be given to the wrong patient because you don't positively identify your patient. And then the process will start again, you shift that patient to ICU. So it is really because of simple error. Which is a human error, identification. So be careful. If the patient is conscious and become very unwell within the first few minutes of a transfusion, or he shows some signs of flushing, glowing and abdominal pain, then this is early sign that this patient he is going through hemolytic transfusion reaction. If the patient is unconscious in the OT and you give him incompatible blood, how you will know? And it happened in some centers. So you have to observe the vital sign. If the patient went into hypotension and tachycardia, that is not explained by the surgery. He's not bleeding and he is not having any drug that causing him to be tachycardic, and he's already anesthetized. So you have to think why he is receiving blood. Is this tachycardia and hypotension because of the blood? And then if he develop bleeding from the skin or from the needle, then he is really hemolyzing because of your blood. Then in this life-threatening condition, you apply the 5-step and you seek early support and advice from critical care and hematology teams. Admit the patient at intensive care unit if possible, and contact the transfusion laboratory. Here very important point also, that you contact the transfusion laboratory immediately to prevent further wrong blood incident, because at the same time maybe that unit which you transfuse to your patient wrongly should be went to another patient. So there are other patients who are at risk. So here you notify because your patient for the complete workup of transfusion reaction, and also to notify blood bank that the unit that issues not for the right patient and other patient is at risk. The testing, I'll discuss them later better altogether of all moderate and severe reaction. We'll go for other life-threatening also bacterial contamination or sepsis, which the patient will present also with fever. Here, as maybe highlighted by Dr. Ahmed, it's maybe common with the platelet transfusion because the platelet, the storage temperature, which is favorable for bacterial growth. And I want also to mention, as Dr. Ahmed mentioned, the double technique method cleaning for the donor, because many of the cases maybe the source of because of infection from the skin of the donor, or it is from initially when you choose your donor, you have to check the eligibility, so he is not having any bacteremia. So it is either from the donor or from the skin. While you are doing the cleaning method, it should be either by alcohol, or some center they are doing the double technique method of cleaning, which is by using alcohol and chlorhexidine, which is giving much better result in terms of disinfection. And the other thing is the diversion pouch, which you are taking, the one who is working with donor collection, to screen for any infection inside the blood. But we are focusing on the bacterial contamination now. So if your patient develops symptoms that suggestive of having sepsis after blood transfusion, like hypotension, fever, then the things you do plus the 5 steps, stressing on that 5 steps to apply also here. Take a blood culture from the patient, peripheral vein and through central line if present, and you start immediately broad spectrum IV antibiotics. It's true that it is difficult to distinguish, but there are some hints which we mentioned in the ABO incompatibility toward hemolysis, and here the things that having chill, rigor, fever after, like for example platelet transfusion and hypotension, this is all toward that this patient likely to have bacterial sepsis, and you start IV antibiotics. Now the choice of antibiotic depends on the local protocol, but some center will prefer to start with the protocol that is used for neutropenic sepsis, which would be appropriate in this setting. Now if the patient presented after transfusion with dyspnea, there are many differential. However, you have to think about life-threatening first. In the transfusion reaction, having high index of suspicion is much better than having low. So if you start and work up the patient, better rather than not recognize that it is transfusion reaction. So is it transfusion related acute lung injury, or transfusion associated circulatory overload, or it is anaphylaxis? So trali, there are different theory behind developing trali. Anyway, I want you to remember that this patient, if he develop trali, he will be some of the patient will have a pre-existing condition, like he will have a lung disorder before to start with, pulmonary edema or COPD, any lung condition, and then you give him blood transfusion, 2 hours of a transfusion, maximum 6 hours. Usually this is the typical presentation. They will develop severe breathlessness and cough, which is productive, with a frothy pink sputum, and patient will be very sick, and he have very really shortness of a breath. And while you are doing your workup, you do chest X-ray, and it will show bilateral nodular shadowing in the lung field with normal heart size. This is to distinguish from the other complication. Here, it is most likely to be, it really need to be excluded because it's difficult really to diagnose. But you give, as I said, high index of suspicion, and immediately you shift this patient to ICU because management is basically supportive with good ventilation and oxygenation. Now, the other complication is transfusion-associated circulatory overload, and this usually presenting within 6 hours. Not necessarily to be less than 6 hours. However, trial usually less than 6 hours, immediate, like commonly within 2 hours. And this usually the patient will have a problem with overload, either because of renal problem, cardiac problem, or liver problem, or also lung problem. So he will have fluid imbalance with more predominance positive balance. And when you give him transfusion, so you will suspect from the clinical scenario that this patient going to TACO rather than TRALI. And he will present also with acute respiratory distress, tachycardia, and raised blood pressure. Now some centers, they apply score for TACO. So before transfusing the patient, they will have a system. Hopefully we are applying here like in ICU. Before transfusing the patient, for example, you have, as Dr. Khalid mentioned, the alternative. So you minimize phlebotomy, you minimize invasive procedure, you minimize you use the pediatric sample, pediatric tube instead of adult tube to those patients to minimize the blood loss. In addition to that, you have to have a transfusion consent. You write the indication for the transfusion, you calculate this score, you write that this patient is at risk of TACO. So you are suspecting before transfusing the patient. Because in one of the hemovigilance here in UK, they found the most common cause of mortality because of transfusion is TACO. And after that, they made some changes in their transfusion practice. Hope we are doing so also. If we find that we are transfusing our patient, for example, in ICU, where the risk of TACO is higher, we are going, like Dr. Khalid mentioned, with the restrictive approach and the alternative, and then we define this score, and we write the indication, and that this patient at risk of TACO. This all help to reduce the incidence of transfusion-associated circulatory overload. Now this table show you the difference between TRALI and TACO, just to help, because in real scenario it is very difficult. Both of them will present with breathlessness, and you cannot really distinguish. However, in TRALI usually it's common with hematology and surgical patient. TACO, those patients who have at risk, like elderly, but can happen at any age as well. TRALI, it happens mainly with the plasma-rich component, like a plasma and the platelets, because of the pathophysiology of it. It's happened when you transfuse patient antibody, which is like a plasma component, rich in this antibody, but can happen also with red cell. TACO with any component. The onset, as we said, less than 6 hours, usually within 2 hours with the TRALI, and within 6 hours with TACO. Oxygen saturation in both will be reduced. Blood pressure with TRALI will be low, however with TACO will be high. Those patients usually are hypertensive, having high heart failure, so their blood pressure usually will be high. Now patients usually they will be at ICU, so if they measure the jugular venous pressure, usually it will be normal in TRALI and elevated in TACO. Temperature will be raised in TRALI and normal in TACO, and the changes in the TRALI, as we mentioned, however here there will be cardiomegaly and characteristic of pulmonary edema in chest X-ray. Then also the echo will be abnormal, Of course, you are admitted the patient and you will have some baseline workup done for him. I didn't expect that one patient admitted medicine patient in ICU that echo usually they are doing for them. So you will see that is abnormal. Trali usually we are not doing, but if you want to distinguish, this all steps will be as further workup, not in acute setting. And pulmonary artery which pressure will be elevated with TACO. Blood count, they mentioned that there will be some fall in neutrophil in Trali and monocyte followed by neutrophil leukocytosis. However, in TACO there is non-specific finding. And if you give, this is very important, if you give Trali patient fluid, they will improve. However, in TACO they will worsen. With the diuretic is the opposite. So TACO patient will improve with diuretic because they have overload. However, the Trali, they will not improve. Trali, the management is mainly supportive. So you want just to support the patient till he get out of that transfusion reaction, the first acute reaction. Now we go for other life-threatening conditions that present with urticaria or any skin changes, and I'll focus on anaphylaxis. So anaphylaxis is one of the life-threatening really condition that patient may experience after transfusion, and maybe also for the doctor and the caring physician. It's really scary and make the physician or the caring panic sometimes. So patient will present with shock and severe hypotension, wheeze, and stridor. Sometimes they will progress to laryngeal edema, angioedema, and these symptoms combined with hypotension. Now it is more common with plasma-rich components such as platelet and FFP due to the presence of immunoglobulin and proteins, and also the other plasma component that patient may be sensitized to. Now it is very important that after you know that this patient after receiving transfusion they are prone to anaphylaxis, you have to be trained how to manage anaphylaxis in emergency setting. Who is ever with the patient first, he should apply the emergency resuscitation of this patient because the mortality is very high, as you know. So, and in addition to that, you have to have your supplementary medicine and technique to manage this patient. So epinephrine must be available for emergency use. So there will be you can do urgent administration of intramuscular epinephrine to treat anaphylaxis. Adult dose is 0.5 ml 1 in 1000, which is I think the same here applied in emergency for patient who is presenting with anaphylaxis. Now if the patient, just to let you know, if the patient is thrombocytopenic and he already transfused platelet because of thrombocytopenia, you don't hesitate to give IM because this is life-saving. So you don't proceed to subcut in like in other thrombocytopenia causes. No, you give IM epinephrine because it is life-saving. And as the 5th step, you have to urgent expert medical care, and after initial resuscitation you can give steroid and antihistamine. This is very important because sometimes some physician will give antihistamine and steroid. It is not a core treatment for anaphylaxis. You have to start with epinephrine, later you can give the antihistamine and the steroid. And those patient, any patient who develop anaphylaxis post transfusion, blood product transfusion, they should be seen by a clinical immunologist. So you are justified to refer this patient to clinical immunologist for follow-up and workup for the cause of this anaphylaxis. Moderate reaction here will include the febrile non-hemolytic transfusion reaction and allergic reaction, but not to the extent that causing life-threatening condition. So either it is fever with some, and this fever should be defined because sometimes it is really not moderate, it's mild fever. So if there is rise in temperature up to 39 or more than 2 centigrade from the baseline of the patient, you consider as moderate, and maybe it accompanied by other systemic symptoms, chill, rigors, malaise, but there is no hypotension, there is no stridor, there is no wheeze, toward other life-threatening condition. And usually when you stop the transfusion, you observe the patient, it will stop these symptoms, and it is not sustained. However, if it is sustained, then you should consider bacterial contamination or hemolytic transfusion reaction. This is for fever, so you have to exclude both. For moderate allergic symptoms, it can present with other symptoms as I mentioned, but it is not life-threatening. There is no hypotension, and there is no really vitally instability like in anaphylaxis. And you can here give antihistamine such as chlorpheniramine orally or IV can be effective. And other supportive measures like oxygen with salbutamol to reduce and alleviate respiratory symptoms. Now I end by discussing the severe and moderate transfusion reaction. Those reactions are the ones you have to work them up by laboratory side. So if you have mild reaction, you don't need to send for workup from laboratory side, only the moderate and severe reaction. So in this case, you send the standard investigation, which will include CBC, renal and liver function, then assessment of the urine for hemoglobin. You take sample also because you don't know what you are dealing with, but you have some hint towards maybe this is hemolytic. So you do the repeat compatibility testing, you do your ABO grouping, and you do your cross matching, and you do your DAT, direct gluten test, LDH, haptoglobin, which are the hemolytic marker. You take blood culture from the patient, as we mentioned, if you're thinking it is bacterial sepsis, and you do your coagulation screen. Coagulation with renal function because the patient may go to acute renal failure or DIC. The unit that you are transfusing to the patient, you don't discard, you retain it to the lab because to the blood bank, you want to see if the patient receiving incompatible blood or there was a problem in the cross matching. So you retain it to the blood bank and they will work it up. Now if this is the initial workup, if a prior reaction sustained, then retain the unit. So you work up the patient and you will observe him. However, if he didn't improve, then you discontinue the unit and you retain it back to the lab. In the lab, they will repeat all the compatibility tests. So they will do grouping, they will do cross matching, and they will do hemolytic marker, and they will culture also the unit. This all regarding the sepsis and the hemolytic transfusion reaction. Now, if the patient he develop anaphylaxis or moderate allergic reaction, then also there is a specific test you send for, which is IgA. Some patient, very rare, but not very rare, somewhat uncommon. Some patient will have IgA deficiency, and when you give them a blood component that is containing IgA, they will develop antibody and they will develop severe. It is depend on the phenotype of the patient. Sometimes it's mild, sometimes moderate, sometimes anaphylaxis to this blood component. Because of that, I told you any patient develop anaphylaxis, you need to send him later to clinical immunologist, so they will work him up for IgA deficiency. And if he confirmed to be IgA deficient, then he will be like a special case. You need to refer to blood bank or to reference laboratory so they can give him IgA deficient component. Unless it is emergency, there will be another decision regarding that. However, if he is deficient in a normal routine blood transfusion, like for elective transfusion, he should receive, which is really indicated, he should receive IgA deficient component. Now, mild reaction, which I expect that majority of you have seen, that when the patient have no change in the vital sign, isolated fever of 38, but not rise from like more than 2 from the baseline, or only pruritus and rash, there is no systemic symptoms at all, no change in the vitals, then you consider as a mild reaction, and in this you restart the transfusion with direct observation. You don't need to discard the unit, you don't need to really stop the transfusion for 30 minutes. No, you just restart the transfusion because it is mild reaction. And you can give the patient, like for example, if only isolated fever, you can give him paracetamol. And if it is like allergic reaction, pruritus or rash, you can give antihistamine. But we are talking about first time this patient experience this transfusion reaction. Now, if he has same recurrent with the subsequent transfusion, he got recurrent of these symptoms, what you can do about it? Now, if he experienced recurrent febrile non-hemolytic transfusion reaction, you can, I would like to say, you can give him a trial of a pre-medication with oral paracetamol 1 hour before the reaction is anticipated. This is in case of recurrent, because some of our practice before that we give to all patients paracetamol and antihistamine. I don't know the practice here. You are not giving it? Okay, so it is only if the patient experience recurrent, because there is no evidence to give to all patients who have no specific risk factor, to give him a prophylactic, we can say, or pre-medication before transfusion. Or if the symptom was a predominant chill and dry gores or pruritus, which is moderate, then you can give non-steroidal anti-inflammatory drugs. But you keep in mind this patient, if he has any renal impairment, if he has any risk of gastric ulcer or bleeding, then you have to balance the risk against the benefit of giving this patient if he needs blood transfusion. But if the patient continue to react, then you have to contact your central blood bank to provide you with a washed blood component. This is the last solution if the patient really continue and you don't have, and still it is mild to moderate. I'm not talking about any severe form of reaction. If you continue to have mild allergic reaction, basically in the mild, there is no evidence to support routine prophylaxis. Sorry, I'm talking only about fever here with chill and dry gores. For allergic reaction, if it is mild, there is basically no evidence to support routine prophylaxis with antihistamine or steroid. However, if it is moderate or severe allergic reaction, it should be use of directly monitored transfusion of a standard component in a clinical area with resuscitation facilities. Means if this patient have a reaction that is you work it up later and you didn't find any cause, like the patient is not IgA deficient, maybe he is experiences this allergic reaction to any preservative in the blood component and it is recurrent, then you try to transfuse this patient if he's really need blood transfusion in directly monitored area, and then you can use antihistamine prophylaxis in moderate to severe, not mild, and then you can use a trial of wash red cell or platelet. If specifically he is showing allergy or anaphylaxis towards FFP, we can use, there is evidence that pooled virally inactivated FFP can reduce that. And basically in all patients, leukodepletion reduce this allergic reaction. Maybe I'm talking about UK's practice where they have universal leukodepletion, 100% depletion. So because of that, I didn't put it one of the method to reduce allergic reaction. However, we are starting now in CBV to do leukodepletion, and hopefully it will be done for all other regional blood banks. So that's all of my talk, and this is a summary for how you can manage and recognize transfusion reaction and how you can deal with it. I take it from UK guideline, and but basically there should be always a local protocol for management of a transfusion reaction, recognition and management. And that's all of my talk. Any question?